This demographic profile of India illustrates the sheer scale of the nation's healthcare challenge. The system is responsible for over 1.4 billion people, and crucially, 65% of that population lives in rural areas. Delivering medicine to that many people requires covering incredibly diverse geography. The infrastructure has to operate in both ultra-dense urban megacities and highly isolated tribal terrains where transportation is scarce. If a citizen with a routine pregnancy or a mild fever bypasses their local village clinic and travels directly to a major city hospital, they take up a bed meant for a critical patient. Multiply that by 1 billion, and the entire national medical infrastructure would instantly collapse under the weight of everyday ailments. The mathematical solution to preventing that collapse is a strict 3-tier filtering system. The geographic principle driving this pyramid is that the citizen should reach their first point of care in a maximum of 30 minutes. Achieving health for all at this scale is a feat of engineering, relying on a rigid hierarchy of population thresholds to place specific clinic types exactly where the data dictates they are needed most. The foundational tier of this pyramid begins entirely with outbuildings. The human frontline consists of accredited social health activists, known as ASHA workers, who conduct community outreach and basic health education right on the doorsteps of citizens. To maintain coverage, the government mandates a strict mathematical ratio. Precisely 1 ASHA worker is assigned for every 1,000 people. This chart sets thresholds for sub-centers, 1 per 5,000 people in plains or 3,000 in hilly areas. As population scales, these link to primary health centers, triggered at 20,000 people rurally or 30,000 in urban zones. In the rural landscape, these primary health centers are the first facilities citizens interact with that contain dedicated delivery rooms and dedicated medical officers. They handle 12 essential service packages. Their focus is on immediate community needs, mass immunization drives, routine maternal health, and early screening for non-communicable diseases. This wide, highly localized base acts as a massive sponge. By catching and treating the vast majority of everyday preventative health issues early, they keep millions of patients out of the hospital system entirely. But when primary care is insufficient, when a patient requires a minor surgery, a blood transfusion, or develops severe complications, they have to escalate. They move up to the secondary tier, community health centers and district hospitals. Within this tier, certain facilities are given a specific vital designation, the first referral unit. A facility cannot simply declare itself a first referral unit. Guidelines mandate 3 uncompromising criteria: surgical interventions, newborn care, and a 24-hour blood bank. The primary reason for these round-the-clock requirements is to handle immediate emergency obstetric care, like cesarean sections. This table of service norms illustrates the drastic jump in capabilities. At the community level, family welfare is categorized mostly as counseling and basic distributions. By the time a patient reaches the referral center, the interventions escalate to complete hospitalization and sterilization operations. This middle tier functions as the emergency firewall. It saves lives by performing acute interventions locally, which shields the highly specialized urban hospitals from being overrun by routine surgeries and complicated births. The apex of the pyramid consists of tertiary care facilities, like the All India Institute of Medical Sciences. The leap in scale, funding, and technological capability here is immense. These institutions do not handle basic clinical work. They are strictly reserved for advanced medical interventions, like neurosurgery, severe trauma reconstruction, and specialized oncology. The primary and secondary tiers simply do not have the legal or medical authority to perform these procedures. Beyond treating the rarest cases, these apex facilities serve a critical secondary function. They operate as medical colleges, tasked with researching new treatments and training the next generation of specialists to feed back into the system. The apex represents the ultimate limits of the nation's medical science. It is an elite, highly concentrated tier reserved solely for patients whose complexity has exhausted every firewall below it. Having 3 distinct tiers of state-of-the-art buildings is medically useless if those facilities operate in isolation from one another. The mechanism that connects them is the 2-way referral system. A patient can be calmly escalated upward through the tiers for a life-saving surgery and then successfully transferred back down to their village clinic for long-term recovery and continuous follow-up. This structure creates the capacity for early intervention. The wide base of the pyramid can aggressively hunt for illness through screening at the local level, addressing health risks before they escalate into hospital admissions. Maintaining this precise flow of patients across diverse topographies, managing the data, and distributing the resources for 1.4 billion people requires immense logistical discipline. The success of universal healthcare depends on this rigorous mathematical geography, ensuring a patient in a remote field has a direct, unbroken pathway to a life-saving specialist.